I want to call upon the panelists coming up to sit there, so we take a 10-minute discussion, and then we shorten the break afterwards a little bit to reduce. So we can immediately start to see if we have any questions. Yes, please, go ahead.
I'd like to raise the first question again about the use of chromogranin for screening.
Yeah.
We saw a very nice diagram of different ways they can present. Everybody's lamenting the fact that doctors don't diagnose them for 4 years. Can we not break this down and say if you have an attack of asthma, for example, at the age of 50, which you've never had before, there's no family history, that reserves a chromogranin A, for example, or flushing unexpectedly after 3 occasions. That's one question. Yep. The second question is, where do medullary thyroid cancers and pheochromocytomas fit into this picture?
Okay, if I start with chromogranin A, I should definitely say that if you have a patient coming repeatedly and with flushing, you should definitely perform a chromogranin A screen, and maybe also later on urinary 5-HIA. But the problem is to use it, as I have heard in some centers, that they use it as a general screening when patients are coming with diffuse symptoms from the abdomen, because of the false positives as chronic atrophic gastritis and inflammatory bowel disease. So I must say that I will not recommend it as a general screening marker, but I mean, you must have also a gut feeling when you see a patient that this patient has seen a doctor for maybe a year or so, and he has not get any correct diagnosis. Maybe that it's worth checking your chromogranin A and start to see if we can go further from that. Concerning markers of medullary thyroids and pheochromocytomas, we have not brought up that in this meeting, but of course we have the specific markers for medullary thyroids as calcitonin and CAA, and of course chromogranin A is also elevated in some of these patients. Pheochromocytomas, chromogranin A is also increased in a considerable number besides catecholamines. And we have also specific tracers in PET for pheochromocytomas, and also, of course, MIBG scans. So, further questions?
Okay, there is a question from a colleague who asked about the possible role for liver transplantation in metastatic NET after primary tumor resection. Liver transplantation for metastatic NETs is the only indication for a metastatic disease. For sure, over the time, some selection criteria has been introduced, and these criteria are mostly related to the so-called Milan criteria. What I can say, just to be short in my answer, is that there are very few cases in whom liver transplantation is indicated, and again, we must be sure about that the patient was free of any other site of disease, and the disease is not amenable with other kind of therapeutic options such as liver resection, radiofrequency ablation, and so far. And again, the last but probably the most important things is a low aggressive disease. And in general, whenever the patient was free from his primary tumor site, we have to wait at least 1 year in order to be sure that there is no progression of disease before putting the patient in the operating room for liver transplantation.
Okay, I think we then move to Dr. Kocha's question.
Well, Kocha, the other London from Canada. I've noted with dismay that the AJCC has made determinations of Ki-67 and or number of mitosis per high powered field not obligatory, optional. And that certainly has not been our approach in Canada, nor do I think in Europe. But I have certainly been presented with situations where there has been disconcordancy between the two factors and the actual behavior of the patient. I've certainly seen patients who have low Ki-67 but much higher number of mitosis high-powered field, and I've seen the exact reverse, very low mitosis high-powered field, but a Ki-67 of greater than somewhere between 10 and 20, and I've further been dismayed to see occasional patients who have low Ki-67, low mitosis in the G1 status, and yet within 3 months the tumor is growing. Some of those patients have been re-biopsied and they are still low, at least from our biopsy specimen. And again, the exact reverse. A patient who's been sent to me who had his original tumor found some 3 years previously. The tumor has progressed a little bit in 3 years. Those markers were not originally done, but we get hold of them and do them, only to find that the Ki-67 number of mitosis per high powered field are in the 10 to 20 range, and yet the tumor hasn't grown very much. So I think there's some problems with the disconcordancy between the Ki-67 number of mitosis per high powered field and actual clinical behavior. And I'm very much dismayed by the AGCC not making this mandatory. So I'd like to get other people's comments on these problems.
So, Dr. Klepper, you want to comment?
Well, nothing is rectangular in biology. However, there are rules, and the rule is if you have a low Ki-67, you have a low growth. This has been the evidence coming out from so many studies that what you mentioned are exceptions. This is my first comment. The second comment is it is also the rule that Ki-67 follows the number of mitosis. It must be. It is a proliferation marker, and proliferation is based on mitotic division of the cells. So there is something wrong. If you have a discrepancy between the number of mitosis and the Ki-67 value, this must be a technical reason. Third, counting mitosis is, in my experience, more difficult than counting Ki-67. And why? Mitotic activity, to discover and to determine mitotic activity, you need to have a very good section, a very thin section, and then you can do it. But in daily life, you have, well, you have, let's say, medium quality sections. And this is then a disadvantage for counting mitosis, but it's an advantage for counting Ki-67. Therefore, I recommend the counting of Ki-67 and not of mitosis.
Thank you, Günther. And then, Anders, you have a question, or?
I have an online question here that I unfortunately cannot interpret exactly, but it's a question regarding the value or the non-value of combining PET imaging with different traces. I showed in my talk that you could increase the sensitivity by combining different PET traces, and the question was regarding combination of gallium-68 DOTA-TOC with other traces, and unfortunately I cannot interpret the question exactly, but my comment generally regarding the combination of PET traces is that what you need in the basic imaging workup is the morphological imaging, of course. That's the basis of all imaging. And then the functional imaging should firstly describe the expression of the somatostatin receptors. When it comes to other applications, that is, when you want to monitor the patient, then you want to see if there are new lesions. You want to see if the tumor grows. And usually you can do that with just morphological imaging, usually CT or MRI. But when the biochemistry and the morphological imaging doesn't fit, then you need additional imaging, and then you come to the functional imaging.
Maybe I can also comment on this question, because I think what the person asked about is that sometimes you see a discrepancy if you look at liver metastasis. If you take a CT scan, you have 10 liver metastases, and you perform then a gallium scan, you have only 5 positive. So if you combine, for example, with an FDG PET with a gallium PET at the same time, could you then delineate more lesions and also get second information about the possible danger of having positive FDG PETs metastases in the liver?
So to sum up this answer, I would say that you need the gallium-68 Autotalk PET or the Octo scan in the basic imaging workup. But then, for problem solving, when you have a patient where the clinical presentation of the patient, the clinical status of the patient, biochemistry, and morphological imaging doesn't really go together, then you need a problem-solving tool, and then you go to molecular imaging, and then you can use a combination of techniques.
Yes.
This is an interesting point from my point of view, surgical point of view, because the most you study the patient, the more lesion you find. Yes. And this probably will change in the future the concept of surgical indication for radical surgery. And on the other hand, probably in most instances in the future, studying much better the patient, probably we are dealing, we will be much more aware about the fact that the disease is quite almost diffuse in different sites, not just in the primary sites as the normal imaging nowadays shows. I would like just to ask a comment about you, Anders. Okay, we are multiplying the tracers in the PET setting. But on the other hand, as clinician, what we would like to have is just one shot, whenever possible, techniques which offer us the information about staging of disease, of the site of the disease, staging of the disease, as well as possible further therapeutical targets. In this setting, probably gallium is the best one PET scan option. Do you agree with this?
Yes, I do. We have not really shown this scientifically. There aren't any large trials yet. There are so far only small trials, but the evidence are accumulating. But I would say that for the basic imaging workup, a gallium-68 Autotalk PET CT, where the CT is performed in a diagnostic mode, that is with the intravenous contrast enhancement, using the 3-phase CT that we heard of, which is so extremely important, then you have an optimal tool to stage the patient.
I think maybe we had to close this first session now. We are a little bit behind time, and so I want first to thank all the speakers for this morning.